So today I'm going to be talking about my thesis topic, which is what does the paradigm of palliative care have to offer the field of psychiatry? I want to note that I'm actually going to be writing my thesis this summer. So today I'm going to be presenting sort of background research and questions that I'm interested in this topic, but don't have sort of a big conclusion I have reached yet. I also want to share that I became interested in this topic during my time in medical school, seeing the amazing work that palliative care teams did, taking care of patients that were sick in the hospital, and also because of my own interest in psychiatry, which I'm planning to apply into a residency in. So, what is palliative care? Palliative care is a field of medicine that's focused on the relief of physical, emotional, and spiritual suffering that is associated with chronic or life-threatening illness. And it is a field that places emphasis on quality of life over quantity of life, unlike a lot of other fields in medicine. Palliative care is not restricted to end-of-life care and should be utilized throughout the course of illness to maximize patient comfort, and also is not to be confused with medical aid in dying. I think there are a lot of misconceptions that palliative care only has to do with death and dying, when really it is about patient comfort throughout the course of illness. So, for some background on palliative care and psychiatry, these are two fields that don't share necessarily the same goals. The goals of traditional psychiatric care are to help a patient achieve remission from their disease and enable them to live a normal and symptom-free life. And this is done through the use of psychiatric medications, as well as therapeutic techniques such as CBT or DBT, as well as other procedures such as ECT. Unfortunately, for some patients, psychiatric illness is chronic and relapsing. And not all patients that are treated with traditional psychiatric methods achieve remission from their symptoms. Additionally, some patients suffer side effects from their psychiatric medications that interfere with the quality of their life. So this can include, for antipsychotic medications, movement disorders such as tardive dyskinesia, also potentially fatal complications such as neuroleptic malignant syndrome, and medical side effects, including toxicities to different organ systems like the heart and the kidneys. Some patients also experience a cycle of involuntary hospitalizations throughout their lives that they find detrimental to their well-being, even if these hospitalizations are stabilizing for their symptoms in the shorter term. So what would a palliative model of psychiatric care look like? In a palliative psychiatry model, the goals of care would be different. They would be to relieve patient suffering and maximize patient quality of life, even if psychiatric symptoms were to persist. Proponents of palliative care psychiatry say that this should be offered only to patients with severe and persistent mental illness for whom traditional treatment has already been deemed to be ineffective, and that this shift in goals of care should be guided by patient desires and should be done while working closely with a psychiatrist. So some examples of what this could look like in practice would be, for example, for a patient with anorexia nervosa, not forcibly inserting an NG tube against a patient's wishes for force feeding, even if a patient is dangerously underweight, or not subjecting a patient with psychosis to an involuntary hospitalization, or potentially reducing the dose of or eliminating altogether a medication that a patient is finding they're having debilitating side effects to. I'm sorry, I'm losing my voice. And this has been sort of a more recent topic in the news and in public discourse. I first became interested after reading this article in the New York Times earlier this year called "Should Patients Be Allowed to Die from Anorexia?" There was also an issue in the American and the AMA Journal of Ethics in 2023 on palliative psychiatry. And this was one article that examined the ethics of it related to addiction psychiatry. And then this is an article from Stats News from earlier this year, from February. So there are a lot of ethical issues that come up when talking about how the paradigm of palliative care can be applied in the psychiatric context. First is the question of beneficence. So the question is, does this approach go against the physician's duty of beneficence to the patient if implementing it means that the patient will still experience psychosis or experience other distressing symptoms of their psychiatric illness? And then there are also very serious questions that come up around non-maleficence and the potential for harm that incorporating palliative care into psychiatry may give rise to. So there are safety concerns both for patients and for the general population and people around these patients if symptoms are not controlled, particularly for patients with psychotic illnesses. And sort of right now, the whole basis for involuntary hospitalization of patients is generally founded in issues and questions of safety. In terms of autonomy, a palliative approach seemingly champions patient autonomy in enabling them to direct their own care and express their own desires and how they'll be treated. But it also raises issues of patient capacity to consent to a change in goals of care to a palliative approach. Because if a patient is experiencing psychosis, are they able to provide consent? Or if a patient with anorexia lacks insight as a feature of the disease, do they truly have capacity to decide not to have an NG tube for feeding? And then there are also questions of justice that are raised. So not all patients in the country or in the world have access to high quality psychiatric care. And there are concerns that some patients could be deemed treatment refractory or severe and persistent and switch to a more palliative care model, when in fact, if they had high quality traditional psychiatric care, they could have achieved remission from their symptoms. There are also questions about patients having delayed responses to psychiatric treatment and emerging treatment modalities that may be effective for those who were previously considered treatment refractory. The lines are very unclear in psychiatric illness of when someone is truly treatment refractory and, sort of beyond hope for what traditional psychiatry can do for them. And I think more so in psychiatry than in some other medical illnesses. So in my thesis, I'm hoping to examine these questions through the lens of different case studies. 1, 2, or possibly all 3, but I'm interested in looking at what is considered treatment refractory anorexia nervosa, severe and persistent schizophrenia, and chronic suicidality in the setting of major depressive disorder. And I'd like to examine what a palliative approach would look like in these cases and what ethical concerns come up related to a palliative care approach. I'm also interested in whether there are elements of palliative care that can be brought into traditional psychiatric care to sort of prioritize patient comfort while also addressing some of those ethical concerns that come up around safety and capacity to consent. So these are some of my references, and I'm happy to take any questions later on. Thank you so much for listening.
Great, fascinating topic, really cutting edge. So thank you for presenting that. Very provocative too, which is great.
So I had read that same New York Times article and was fascinated by it, and got into an in-depth discussion with my sister-in-law, who is a psychiatrist, about it. And I was just wondering, given that you're thinking about going to that field, like, did you put yourself in the position of having to be the treater in any of those cases that they discussed, like the like not force feeding, the person with an eating disorder. And because I thought those were so fascinating, because quite often when I talked to my sister-in-law, she was like, oh no, I would feed her. And I was just like, did you read the article? Would you really do that? And I'm just wondering how that framed your thinking moving forward potentially into that field.
I think that's a really wonderful question, and I appreciate it. And I think that it's a question that I struggle with. I think that there are sort of standards of a field that you go into, especially as a trainee. You're not going to reinvent the wheel, you're going to learn. And even in my psychiatry rotations in medical school, I've seen with traditional treatment, medications and ECT and so on, people make really amazing recoveries that made me want to be a psychiatrist. And then you also see people suffer. And you read personal accounts of people with psychiatric illness who had really traumatizing experiences being involuntarily hospitalized. And I'm very sensitized to the whole anti-psychiatry movement. So I think that's sort of why I was drawn to this topic, because it's a field that I want to spend my life doing, and I want to know how can it be done in the most ethical way that prioritizes the patients and puts them at the center of care while also maintaining their safety. And I think it's one of the most complicated fields in medicine for that reason.
You know, I agree. Thank you. I
Yes.
think it was fascinating, and I think that it's a field that the ethics really, need to be explored. So, congratulations, really good.
Thank you. Thank you for your question.